the participants are listening and they must be eager to ask questions. They're going to ask a lot, but there's a session for that. We are changing. Can we give him a clap? Can we just do that? Maxwell, have you received our clap? Now we are changing the program a bit. Other members were saying first go for lunch and what, but we are also practicing. Commissioner, today we are really on your neck. We shall first go for panel discussion, which will take a short time. It's a short, only one area per person. We go for lunch, then we come and open for discussion. Yes, panel discussion first. So Maxwell, can you come and take over this? The panel discussion. And I'm requesting my team to support me with the setup. Let's do it very fast.
So we are going to have from the ministry, we are going to have Dr. Ochakachon. You are most welcome. And then we are going to have the representative from the Uganda Health Information on non-communicable diseases, Mr. Ogwal Jimmy. Welcome. We are also having Dr. Senabulia. You're welcome. From the political wing, we are glad to see with us here the resident district commissioner, Madam Lady. You're welcome. I'm going to humbly request all the district health officers of the 3 districts, Dr. Marina, Dr. Butchman, and then we have a representative from Kwale district, Dr. Ogari. We were supposed to also have someone from the city health office. Do we have anyone? I unfortunately tried, I couldn't see any. Okay, from Faber, yes. And then from the academia, we have the Deputy Vice Chancellor, Academic Affairs.
Yes, sir, your policy.
Give us, be with us here. The main question is going to be asked by my colleagues here, but I'm just going to give you the curtain raiser. Dr. Charles Olaro talked about everyone's responsibility. I wanted to start, there were things that he mentioned towards the end of his slides when he said limit sugar, limit alcohol, dance a lot. What else did you say? So I am going to pass this microphone to each and every one of you here to just share with us, only on that, in 1 minute, what you identify with in any of those recommendations. Have you understood? I said, Dr. Charles mentioned at the end of his session, in his address, that recommendations for NCD 5 is limit these activities, these lifestyle patterns. Limit alcohol, limit sugar, salt, tobacco, stress, and in stress he emphasized that you dance. So I'm just going to ask before you even introduce yourself, because my colleague is going to come over that. This is just a curtain raiser. So which of these do you identify with most? Thank you.
Thank you, moderator, for this panel discussion. Dr. Richard Oki, I'm not CDF, I'm a CDF officer, but I'm taking that soon. I think I'll handle the last one. Stress. Yes, stress. No doctor can manage stress. Apart from the honor, somebody who is stressed. It's the person that can help the doctor to manage. And as the commissioner said, there are so many ways. Yesterday when I was visited at a very center, I told them that the fatigue of last week, we almost push it to the next, coming to the next week. That means fatigue is one of the cause of stress because of the workload that for us health workers face because of limited work and number of staff. So when you go and dance, you are not going to express alone. You also do physical exercise, which also great for your body. So briefly, that is how stress is managed. Thank you so much.
Thank you, the DH Royan. I didn't understand. I might have misunderstood the question. What do you identify? Why do I identify with as a person? Yes, I identify with sugar as two things: sugar and salt, as a person, and it's been difficult for me to limit those two. So, as a person, I identify with those two as problematic for me. And so, of course, it's something that I learned today, and I think I need to start, having change. I need to change and start limiting those two.
Thank you. My name is Ian Millian, this is Lena District. Mine, just like for DHO, is about salt. And I find myself not able to control it because sometimes I don't cook myself. What keeps me wondering is when we were growing up, there was this big salt which they would sell in glasses. Yes. Though we had its own challenges, but we were used to picking and putting the right amount. But of late, daughters are failing with this small salt to measure it well. So sometimes you go home, the day has been long, the food is very salty, you have been working, you are tired, and you need to eat. So you end up eating it. Then as I share this, as I move the microphone, one time I had a medical problem and I was being examined in the theater, and the doctor told me, so you mean you had a lot of salt in your food? I said, yes, doctor. And then he told me, stop it. I tried my best at least to stop it, despite this challenge. So awareness is key. It makes us act. Thank you.
Yeah, thank you, Dr. Ochi and Patrick Wichan, DHO leader. Sugar, I think I last took sugar, refined sugar, this one with crystals, in 2015. So up to now, when you see me taking tea, black tea, it's without sugar. So, yes, I eat in a number of places, sometimes out of home. And when I find salt too much, much in that place, I give a caution. If it persists, I move away. And so I desisted from adding salt. I have seen, as it was earlier said, some people before they test, they're already adding salt. I don't do that. So I limited that. It is very difficult to cope with stress. And once in a while I dance, and just to shake off the stress, and partly because I want to do exercise. I am one person, my home is about 4 kilometers from here. Sometimes it's very interesting to find me coming to office walking. And yet I have a vehicle, I have an office vehicle as well. And so in a form of exercise I do, there is a place called Balpe, that is towards our home. Saturday market, sometimes when you find me by the roadside walking that side, don't offer me a lift. I do it. Thank you.
My name is Ogale James Patrick, medical officer for Local Center for. I still want to impound on what he has just briefly touched. And the first presenter mentioned it in the middle of his presentation, that is sedentary lifestyle. You are from air-conditioned office, you move in air-conditioned vehicle, and you are going back to air-conditioned sitting room or bedroom. This is very advanced because your body won't have time to use those redundant fats, the redundant energy reserves. I'm a medical officer at Aboke Health Center for. I try to dodge this by one. I'm in the ward reviewing my patient. I don't have time to sit down. If there is a procedure to be performed, you know, when you're performing a procedure, you don't sit down, you stand for almost 30 to 1 hour, or even some difficult one can go to 1.5 and 2 hours. So in that way, you are trying to burn down the redundant energy reserve which is in you, so that it doesn't cause you cardiovascular issues. So this one goes to my colleagues who have the 3 or 4 categories I have mentioned. You have your office which is air conditioned, you sit there throughout, your vehicle air conditioned, you move back to your home which is somehow air conditioned. So let's take care because it predisposes to non-communicable disease. Thank you.
Thank you. So what I identify with, I should say, I think my challenge is sugar. I like sweet things. So, yes. So, I should say there are times I say I'm on zero sugar challenge. I can take tea without sugar, maybe a cup or 2, but after a week or more, I say, why should I take tea without sugar? So, and if there is soda, I can say I'm not taking today, but after the next 2 days, I feel like I should take. But for the others, exercise is simple for me. I can exercise, I don't take alcohol, I don't smoke. Salt, I can reduce, but sugar is a big issue. So I think I'll have to do more on that. Thank you.
Yeah, thank you very much. My name is Jim Ugal. I'm an epidemiologist at the Ministry of Health. I work as a senior muscle statistician. There is one thing which Dr. Oyuk mentioned, but the moderator did not bring it out. There is one indicator which it has failed us, we failed to measure it. It's one of the SDG indicator, household and ambient air pollution. And I work with the School of Public Health. I'm a focus on Ministry of Health Bureau of Statistics. I'm also a focus on Ministry of Health Uganda in East Africa. Health Technical Staff Working Group. And in all these areas, all these organizations I'm working with, we have failed to come out with a clear measure for this indicator. Now, all of us sitting here, we are exposed to air ambient pollution. Whether you're in the kitchen, whether you're in the city, area. And once with those who stay in Kampala and those who stay in the city, we have failed to mitigate, we have failed to measure how much is it in each city area. So, since we are all exposed, what do I do? I'm trying to use mask. It's mask for the mouth whenever I'm coming to Kampala City, whenever I come to the office, because we have taxis which are older than me in age, moving on the road. So I've tried to use the mask to cover myself, to try to avoid inhaling some of those pollution, but I've still failed. So we are all candidates, given that here is a city, but how best can we do that? Maybe Dr. Yo, simple advice, but it's something very hard to prevent. Thanks.
Thank you. Isaac Sinami is my name. Yeah, so I think I can talk about stress. I live a life that is so much provocation. Border pollution, at work, supervising. I'm privileged. I grew up so fast in my career. So that comes with responsibility. So that's all stress. But how do I manage it? I create opportunities out of stress. I'll give you an example. I head the outpatient department at the Heart Institute. So every day I get a report about how many people have been turned away. So for the last many years, that's a constant stressor. What opportunity did I create out of it? Go to regional referral hospitals, empower, build capacity. Go to mid-level providers, empower, build capacity. Indirectly, I'm channeling the traffic. So that's how I manage stress. Sometimes at home, I was giving an example to one of my new friends, one of the co-PIs, that I realized they were spending a lot on juices. Because to make a glass of juice, you need so much. How did I deal with it? Because it was a stressor. I told them, need no juice, pack them, fruits, cut them. But also, of course, the kids love the juices. I said, okay, once you seal that thing, give it to my chicken, such that the egg yolk is more white. So I feed them with the egg. So I create opportunities basically in everything that is stressful.
Professor Kaha, Grade 2, DVC University. First, I want to know, Dr. Anyolisa, if you are a Catholic priest, because you want us to confess our sins. The only thing about the Catholic priest is they allow you to go into a box and then you tell them, no, but now we have to confess before everybody. So, anyhow, we'll confess the sins. So, Dr. Charles Oyo caused us a lot of problems with this presentation. I would say, I think my big problem here would be the sugar. Although I have significantly cut down on sugar and increased on the honey. And usually I take sugar in the honey but finished. But now, someone is telling me that the sugar in the honey is also bad, so I would want the doctors to make up their mind, really. If you don't want us to have sugar and also honey, we will leave it. But you need to make up your mind about that. The other big problem for me is this sedentary lifestyle, because the nature of the work I do is running meetings, very many meetings, as we all know. And usually when I go back home, and because I'm running meetings, I'm also fiercely academic, and I have to do my research work and book writing and all those things usually in the night. So I can sit very long hours at home doing work. And this is a really big problem. But I always try to do a walk, especially in lunch hour walk around the university, really long walks. I love to walk. And then occasionally I play golf with Professor Menchi. it's taught, it's something that the new kids are learning to do, but I found that it's very useful. The other one is stress, and stress is all over the place, at the workplace, and even at home, and in the community, family, everything is stress all over. So I love to dance, like Dr. Charles recommended, but sometimes my knees complain, but I do love to dance as well. Thank you.
Can I respond to the confusion because honey and sugar, just know that it's all sugar. And when you upgrade to honey, you actually upgrading your pocket as well. Because 500 mils of honey is like 15,000, right? It's equivalent to like close to several kilograms of sugar. So you're expediting. The body just takes a little longer to make it the sugar that is refined, but it eventually does. So minimize what you put in your tea. Don't put a lot. I know it could be a sweet tooth, but we apologize. We many times say safe things, but they are not entirely as safe, and we cause no trouble. Thank you.
Thank you very, very, very much. Can we clap our hands for the wonderful Prof, I am very sorry if I have become a priest, but just for the sake of our learning, I have learned a lot from all these responses. And one of the take-home that I have from these responses is that we are talking about something that is complex. That I am a sociologist, and when I hear these responses, you can see there is no clear-cut solution to these problems. They are complex, look simple, but difficult to deal with. Everyone experiences it in different ways and has their own ways of responding to them and has their own perspectives of this problem. And so I just wanted us to have this small thinking, because we are the face of the community. We are the ones that are going to talk about this integrated care. But it starts with us. And I'm glad to hear all these encouraging responses and also challenging. These testimonies that we share, I think we learn from one another. I have picked a lot about the difficulties in adopting some of these mechanisms, these lifestyle things. But I think that we just need to have positive attitudes, do bits of what you can do. And I think the sugar we can, I think in the next few time, maybe we can do away with it. As the presentation was going on, I whispered to Prof. Omech, as a university, can't we even just come up with a no sugar policy and then change the budget for the sugar into juice or fruits? Because we are not going to just talk and not act and not walk, whisper. But I think it is something that we need deliberate actions on. And unfortunately or fortunately, I'm speaking to my professor here who will have to back me. No sugar at the university.
I will not back you.
So thank you, colleagues. A round of applause again. We are going to have the last question that's going to be given by Professor Julia. Thank you.
Thank you so much for talking about your sins. It's good I didn't talk about mine. I would like to ask the last round of questions to our panelists. In our various capacities, we have health experts here, we have political representative here, we have academia here, a senior researcher who deals with also policy issues. All of you deal with policy issues. We have them. Now the question is, in your respective field or expertise, what is your perspective on integrated care? We have been talking about integrated care. Remember, I gave an example of the bank. You stand here, you go there, you go there. So what is your perspective on integrated care, on non-communicable diseases, and policy framework? You can answer any area. Only one question each, and this is the last round. We can start with Dr. here.
Yeah, when you are in a class and you sit next to the teacher, you are the first to be picked. Yes, the integration. We in the city, when Trump made a decree, and for us in the city to move ahead, the new health facility within the city was piloting the integration system. For the services, but now we are talking about the NCDs, non-communicable disease integration. Now, my take is that as a doctor, when the patient comes, I need to handle this patient holistically. I don't say maybe this is a diabetic clinic, but there are complaints that patient presented with. First hand diabetic, then I send the patient to the next doctor to handle. Now that's what we mean integration of this of the management of NCD. So we see the patient holistically, all the patient's problem, handle it by that particular clinician we see the doctor, and they will receive a better services. That's what I got. Thank you so much.
Thank you. My perspective is that it really should be patient-centered. That the integration should look at the patient. Should focus on the patient and engage the patient in making decisions that will support the management of the patient. And also, the patient should be involved in planning and also identify ways in which his or her problem should be managed. So it should be patient-centered. That's my perspective of integrated health.
Thank you. My perspective is that maybe I share the experience that as we are trying to integrate, I've seen us still having stigma because now it is the one-stop center. I call it in my later that our dispensaries are not very accommodative. It is in the open and you're giving drugs to this diabetic patient, to this HIV/AIDS patient who would not want anybody to see what is going on. So I would think we then need to do some overhaul of our design of the health facilities, that it is private, and also as Dr. Dick mentioned, you have to spend a lot of time on this one patient to try to make even early detection. This takes time, meaning that in my own perspective, it will make the place crowded and then they spend more time in the health facilities, and tomorrow they will not want to come back because of the time they're spending in the facility. Thank you.
Thank you. Integration. In my perspective, I know that, and all of us know, resources are never enough. And so having a one-stop center is the best way to go. But also it improves accessibility and availability of healthcare. I am looking at a situation where somebody is diabetic. Gone are the days when you would have a diabetic clinic as a standalone. Now this patient also is hypertensive. The next appointment is tomorrow. And the patient has to travel back home and return to work. And so if we have this one-stop center, first of all, as Dr. Madinga said, we shall be client-centered. But also we shall be using the limited resources for giving out the maximum output efficiency. And I'm happy that MCare is coming in that regard. I remember the inception meeting when I remember talking about Pen Plus, okay? Pen Plus, where we want to have these services decentralized. But also when it is decentralized, we train the human resource to handle the cases at that level. And so that when it is NCD, it is screened even when somebody has come with or malaria. I come for malaria and I'm 30 years and above. I'm being screened for NCD. And then we avoid the missed opportunities. So we find one healthcare worker doing multiple things, task sharing, so that we use the resources effectively and efficiently. Thank you.
Thank you. Before integration, we used to have some cadres within the hospital, within the unit, who had specialized only on one thing. So, these pseudo specialists tried to resist it. But when it was broken down to its simplicity, people started understanding it. In Aboke, we have clinics, the acute care clinic and chronic care clinic, running side by side. So, when you reach acute care clinic, for people who did not first know, we have a triage, which is the entry point in our hospital. The triage is headed by assistant nursing officer, who with her team, all his team, does everything to segregate which one is showing signs of acute care, who is showing signs of chronic care. So in the first place, we segregate them. People thought it was going to delay our patients, but we have realized it's the fastest. So we have other cadres who handles chronic care, and we introduce, acute care. We introduce cards. These cards, there's red, blue, and then yellow, with well-defined cases on them. Red means needs emergency, immediate attention. Blue or green can wait a bit. Yellow is next to red. So we handle them like that. Then, patients for chronic care are sent to chronic care department, the former HIV clinic. We have turned it into that, which includes mental health, diabetic patients, hypertension, and the rest of it. Chronic care, which needs admission, we have a general ward. I'm one of the officers in general ward, as well as antenatal care and maternity. So we are only 2 doctors. When you are off like me today, you have to be in chronic care. When you are on duty, you must look at maternity, because maternity is the entry point in the hospital, and the eyes of the government and everybody is on maternity. So we assign you there permanently. As you were seeing me moving out, I'm still even managing a diabetic patient who came with the undetectable glucose level. But we started him on soluble insulin. Now I've told them to now fix on Mixta. So that is how we are running it. People at the beginning thought that this would create double work, but we have found that, as you have heard, somebody was saying that if you want to hide a secret, you put it in writing. Our people, 6 qualifications, we are not reading and we are not getting new things. Now with integration, these people are beginning to read, because this month you are here in general ward. Next month or after 3 months, you are taken to go to antenatal to go and see mothers. So we are always sifting them like that to different departments, so that we encourage you to read, to be having, and we have strengthened CMEs. CME is headed by district health educator, who is already assigned. One is in Aboka Health Center 4. So we make sure that our CME is running to bring up those people who have specialized in a department. Thank you.
Okay, thank you very much. And it is good that you have spoken before me. So, from the Ministry of Health perspective of integrated services, it is not something new, like my colleague here has mentioned, but it is just reorienting the health workers and reorganizing service delivery. Why am I saying it is reorienting? All of us are trained in our training as doctors, as nurses, midwives, clinical officers, to handle all these conditions. Not only HIV. You feared to mention that some people were only managing HIV. But the same patient who has HIV can also have high blood pressure, can have diabetes, can have cancer and any other condition. So why do you want another doctor to be the one to manage? So we are all trained to manage all these conditions, but we disorganized our system to focus on a particular condition and leave the rest for others. So the Ministry of Health perspective of integration is to reorient health workers. One, like he has mentioned, some of us had forgotten how to manage diabetes. We had forgotten how to manage hypertension. And those of us who are not managing HIV, we had also forgotten how to manage what? HIV. So we're saying you are a health worker to treat all these common conditions. So let's, through CMEs, through apprenticeship, through our colleagues, let's learn all the common conditions. And I'm happy you have mentioned that in your facility, you are doing that. And then, it is also context-based. We have mentioned here that you can have a Health Center 3, which has 2 clinical officers, but there's another Health Center 3 which has 1. There's a Health Center 3 which handles 100 patients every day, another one has only 10. So this integration is also context-based. So if I'm in a Health Center 3, and for example, I have the means to do, say, HbA1c, because they are there, while there's another Health Center 3 which does not have that means. How do I provide the same service with the other Health Center 3 which has all those resources? So integration is context-based. What resources do I have, and how can I rearrange the human resource, the lab resource, okay, the medicines and supplies to provide the best care for all these common conditions? Thank you.
Thank you very much. When the issue of integration became across more pronounced, and during the course of discussion, 2 hospitals were picked as a benchmark, Lira Regional Referral Hospital and one of the community hospitals in Chirora. I was in that meeting. So I asked my neighbor, why are we leaving out antenatal clinic as a benchmark? Antenatal clinic, if anyone can bear with me, there are very many things they do. They do only screening, HIV, TB, malaria. What else? In nutrition, they do screening. In the HIV integration and antenatal clinic. And as a data person, we get all this report from antenatal. 1 midwife, 2 midwives, and they are doing this. So why can't we go to antenatal clinic and first learn from there? Then maybe if we are talking human resource, then we bring them. Another thing
integration is all of us have been to the bank. Bank have a very big hall where you can get a loan, deposit, withdraw, everything. So why can't we create an environment, structural issues? We will assist you to work where can do integration. Thank you.
Thank you. I'm learning, and I'm glad I came. And so, yeah, integration. One, it brings together efforts, resources, it creates efficiency. I know from the offset it looks hard and impossible, but when you dissect it to the detail, it's actually the most simplified thing to do. And I'm glad my brother here is bringing the antenatal, the lessons that you can learn there. I didn't like upscaling in my dream because these midwives were doing so much, but their efficiency used to strike me because they could actually do so much in such a short time and they will have results. So we can learn from that. Yeah, so the experience I have, one of the friends here said, the Pen Plus. I lead the Pen Plus effort in this country. And for me, I call it unanswered prayer to the childhood passion. Because growing up with limited health care, and I saw the challenges even in training, when the funders of that program reached out to us, for me it was a golden opportunity. Why? I work in a tertiary center. We tried to do integration in the tertiary center. It failed. Dr. Mech knows how our diabetes clinic was running on Wednesday, hypertension on Monday, neurology on Friday. So a patient has 5 conditions and they have to come Monday, Tuesday, Wednesday, Thursday. We tried until I remember Professor Mayanja, who is part of our program. We sat and we said, Isaac, I think the easiest way to do this is let's talk to these specialists and we choose what is the predominant condition, and therefore the patient will be assigned to that clinic. That if hypertension is sorted but diabetes is hard to control, let them attend the diabetic clinic, but that patient should, all the other things should be considered than sending them to, because when you send them to other clinics, they have 5 prescriptions, confusion, they have 5 sets of drugs, so you end up draining your pharmacy. You see that? So they can run out of your prescription. Actually, it caused a mess. So when Pen Plus came, for me, it was a great relief to try out something, and it's working because we picked 4 disease conditions: heart disease, which is represented by rheumatic heart disease congenital, and that responds to all the cardiac-related conditions. The capacity you build at that facility, they should be able to treat all the cardiac-related conditions. Sickle cell, it's a big burden. All the hematological issues. Now, where we are seeing blood transfusion becoming better managed because of the sickle cell clinic. Type 1 diabetes. And because we know when you look at the sugar controls in the nation, we're doing so badly, but they're talking about type 2. So when we introduce type 1, indirectly even the type 2 are getting sorted because there is HB1C facility available and health workers are monitoring their patients. Also, of course, people say the workload. The sites where we are, they become more efficient. They manage you because we're now in a quality phase. We had the number phase, but now we're in the quality phase. We're targeting quality. So when you're managed very well, you give a month, so that decongests the facility. So for me, it's an opportunity, and we should embrace it and see how we can support it. It creates efficiencies, and the patients, yes, that one day, they commit in 3 months, even if they spend the entire day, but at least all their needs are met. Tomorrow, I'm going to miss my clinic at the UHI. It's one of my best days in a week because I run a clinic. I'm integrated in a way because when you manage a patient, people used to complain, but that doctor is slow, it takes long. I said, is it your time? It's my time. And why I would take time, not on everybody, depends on their need as they walk in. Somebody said it's patient-centered. I will give you those 30 minutes, but it's going to save me 4 months. I won't see you in 4 months. And then when you come back, you are so stable. that this patient is going to teach me how to farm, is going to teach me how to raise children. You understand? So that's also part of integration. That sometimes you get so selfish. You say, oh, my time clearing lanes, but me, I'm investing. I'll sort you. I don't need your money, but I need your wisdom. When you're asking them, okay, how have you been? How is your business? I'm writing notes because he has successfully managed his business because his health is sorted. And therefore, when I do the same business, I'm an expert. That's integration.
I think I'll start with a disclaimer because somebody set me up. Usually when you ask somebody to be in a panel, you let them know ahead and you give them the questions so that they can prepare. So they just ushered me in here. And then secondly, they put me with all these experts, medical experts. I'm expected to say something also. So I think I speak as an artist, so that is my disclaimer. You see, sometime in the late 90s, early 2000s, there was a guy called Mandela who came up with a new model of the petrol stations in Uganda called City Oil. So before City Oil, you would just go to a petrol station and then put fuel. And then if you did anything other than putting fuel, you have to, maybe if you have a punctured tires, you have to fix it, and that is all. So Mandela built his first integrated petrol station where you go to the petrol station and you put your fuel, and then you have an entire garage there where you can fix your car. And then there's a supermarket where you can also go and buy supplies. And then there is I think the most sophisticated coffee shops in Uganda in the same place. And it became a model that has now been borrowed all over Uganda. And I see this health model in the same way. For me, the most important part is the patient-centered element. That means the person is at the center of everything. So you take your time, if you need to take it, to attend to the patient, rather than the patient being running around like a butterfly to try to fit into the system. Also, from Professor Mechi's presentation, you see that these sicknesses are like, I would want to call them a devalue chain. Because if I call them a value chain of sicknesses, I would be sounding like a madman as if there's some value in sickness. So if maybe we could call it, if I could invent the word, devalue chain of sicknesses. So they're all integrated. He said if you find hypertension, the likelihood is that diabetes is also there. The likelihood is that HIV is also there. So that is, this is basically a family of sicknesses. An uncle, and a brother, sister, and anti-sickness. They're all likely together. So you might as well attack them together. So I think it's a great idea. And I'm one of the greatest fans of this project, Professor Mechi's project, because for us as Lehigh University, the integration goes even beyond the treatment, that at the center of that, the patient's at the center, but there is teaching, there is learning, there is clinical service, there is research, there is data harvest, and then also when we build our 5-star hotel, we will also have a medical tourism. So all these are multidisciplinary interventions on the same patient to make sure that it's something more. So I think it's a great idea. Thank you very much.
What you have mentioned is what you have mentioned is stakeholder engagement, because integration is not only a health issue. You have education, you have agriculture, you have the family, you have the community. So my perspective, the other perspective of integration is that, a number of stakeholders should be engaged.
Yeah, thank you. I wanted to actually thank you, Doctor, for bringing this issue up about 10 plus, how it has now worked. Because many people could be hearing it for the first time. Okay? Package of essential non-communicable disease intervention. That's what they're calling 10 plus. And it was WHO initiated. Uganda brought it on board in 2023. And I think Nakaseke and Umi are doing extremely well. By December last year, they had already received over 2,700 clients. These are clients who are accessing care from tertiary levels, but the capacities of the nurses and the clinical officers were built, and then they're able now to see clients at that level. So seeing M-Care, I think the entry point was building the capacity of the primary healthcare workers, and they're in line with that strategy. So that's why, as district health officers, we're extremely happy with the initiative because it fits snugly into the WHO approach. The only lift that we need to borrow is from the consultant, that we need to engage with him more because he seems to be having a wealth of experience because they're the ones who initiated it. Since 2023 up to now, I think that would be a good distance. Thank you.
I must thank him for bringing in the partners in the management of these NCDs. I'm very much hurt when I see a client I have managed successfully from hypertensive emergency, a DM patient I've managed from undetectable sugar level, coming back when he's having deviated face and unable to speak. What do I mean? You give them information that the disease or the sickness we are dealing with is not curable, but we can control it to a manageable level. 6 months later, she has left medication, comes back with this complication. I'm therefore bringing my community workers. I'm happy they are here. The community workers are holding the barazas. They should be chipping in, telling these people also what we are learning from here. That when doctor gives you medicine to go and take for 2 weeks, first encounter I give you for 2 weeks, so that you can come back and assess how it's working. Then next encounter, if it's working well, I raise it to 1 month. But they go back and sit there because now they are feeling well. So I'm throwing this to the community health workers. Good enough, the Jews are there now backing you. Try as much as possible. We eliminate these NCD complications, much as it is not curable. Thank you.
Thank you very much, our panelists. You have something?
I just wanted to highlight the idea, the element of innovation that we also doing at Clear University, especially with nutrition. That we're also producing porridge and other kind of food stuff to take care of people with anemia. And I think Professor Mench also had a project before this, a DINO project, where they were actually developing nutritional material for people with patients with Nordic disease. So you can see that the integration goes beyond just clinical service to even innovating on nutritional materials that can help supplement the medicine. Thank you.
So we were not wrong to choose you. No, you're well. So let's start with panelists. We had a lot. They've all talked about integration and they've taken it up. We only learned about CME, that is continuous medical education. While we look at this integration and care, we should also look at the context. We're looking to all that. We look at taking time to deal with that patient. Also, for us in finance, we call it cost-benefit analysis. Cost-benefit analysis. So the patients benefit more at a lesser cost than coming for 5 days. It is too much. Remember, I gave the example of banking. So can we thank our panelists so much for their wealth of experience. Now, the next session is, they are aching. There's a discussion session, which we are coming back after lunch, and members here are waiting to ask or contribute to those questions. So we thank the members. Right now, we are retiring for lunch, and then we come for a short time and we close and wind up the day so that those who are traveling back can travel and reach in time. So at the moment, I think I wish you well for lunch. Enjoy your lunch. Bon appetit, but eat carefully. Drink it carefully. Don't overeat. Yeah. Eat carefully. We have a consultant here. We have no sugar.
Around diet. My name is Dr. Samson Udo. I'm a co-investigator on the MCare project. I also double as the acting deputy chief for the Directorate of Graduate Training and Research at Lira University. I'll be taking you in the last segment of our program here, which is really just a discussion. And it's my hope that you will participate, engage us, ask the questions, make your submissions, so that we leave here when you are all satisfied. Don't leave this room when you have a question. Make sure that all your questions are answered before you exit this room. Therefore, in the spirit of NCD and MCare, may I also request you to stand up and we shake a bit. We shake this lunch a bit, and then we embark on our program. Find a good space. Find a good space, and then let me invite my friend here. Sam, you come and help me and we shake these people. Thank you.
Yeah, thank you so much. My name is Dr. Samson Udo. My name is Samson as well. And we're just going to do some simple, I know we have eaten food. Maybe it is somewhere in the chest. I don't know, in anatomy, maybe it is reaching somewhere here. So, we're having three sides, so yam, lira, and kore. Which this figure has the simplest word? Yam? Kore. Which one is easy to write? Lira. So, let's do like this. Let's space our legs a bit. Ensure your neighbor is not occupying a lot of space. So we're going to write lira. I think that's even called as 4 letters. Lira, so for William also about 4. Now, should we write all of them? Because all of them are very important. We choose which one? William, I think most are voting for William. I'm glad the DHO is there, and I think it's going to write very well. You observe as he writes, but you also do the same. So we're going to use our body parts for writing. And the most part that suffers when you have a lot of weight is the lumbar bits of your spine. No? So we're going to write Oyam. The first letter is O. So let's start O. The capital O. O. Then capital Y. Y. And we are there. That's all. Then capital A. And then lastly, capital M. Thank you so much.
Thank you very much, Samson, for that energizer. And also allow me to recognize them. These are members of civil society organization, Global Forum for Development in Uganda. They are represented here as well. We work with them on another sister project, and we are happy to engage them in this launch. Colleagues, ladies and gentlemen, we are here for the last segment of our launch, and the essence of this segment is for us to have a discussion on what you have heard from morning up to now. Second to that, we expect you to ask some questions. If you have a question that you want to be answered by the experts here, or the principal investigators, or the co-principal investigators, ask the question here. But allow me to start by echoing the essence of the MCare project. MCare is focusing on two issues. One is the issue of NCDs, And usually when we talk about NCDs, we pay close attention to the grandmother and the grandfather of NCD, which is usually hypertension and diabetes. And then we bring others on board, such as cancer, to mention but a few. But I want to also bring to your attention that that is a big part of the MCARE project. And that is where we talk about the WHO PEN Plus. PEN stands for Package of Essential Non-Communicable Diseases. And we are planning to offer that package in primary health facilities. The second part of our project is what we are calling the Mental Health Gap Action Plan. Mental Health Gap Action Plan. And that one handles issues of mental health conditions, starting from depression, anxiety, substance use, to mention but a few. And so in the spirit of MCARE, we really want to find people who have multiple morbidity. You have aspects of this mainstream NCD, but you also have aspect of mental health condition. And so our conception of multimorbidity is a bit expanded. And the new addition to that is the aspect of mental health. We were having a conversation during lunch, and it became a bit strong that we paid good attention to diabetes, hypertension, cancer, to mention but a few. Allow me to open our discussion by asking a question. How can we successfully integrate aspects of mental health in this MCARE project? Because it looks like what facilities are already attempting to do or are already doing is the aspect of integrating the mainstream NCDs, diabetes, pressure, cancer. How can we successfully also integrate issues of mental health as we implement MCARE? Because in this project, we are saying multimorbidity means have at least one of the two. Have at least one mainstream NCD and also have at least one aspect of mental health. Then you say, yes, this is our project. And we will not be successful if we did only one arm and we forget aspect of mental health, which already from our morning conversation we are starting to forget very, very, very early on. Allow me to open this discussion by asking the experts in the room, how can we mainstream aspects of mental health in the MCARE project so that we have this holistic, patient-centered approach to integration, so that the objective of the project is achieved. We have a second mic. Feel free to put up your hand, and then we can start the conversation here. She's the assist. Thank you. Long press. Thank you. Then we have another hand at the extra. Thank you.
Before I try to answer, I want to even make it worse by stating that people believe mental health is spiritual. The witchcraft things have worked. And I have also vividly seen people who have mental problems taken to church, they are prayed for, and they get up. And that makes it a very tricky situation. Because the person will believe that person was bewitched. But having said that, I want to emphasize that we need more counselors. If you see in our government setting, counseling services are only mentally referral hospitals. Yet these cases are down there. Actually, you hardly have a function where you have not had many mad people, let me call them like that, coming. Two, we need to have, yes, as you have said, multi-sectoral approach, because some of our youth who are in drug abuse, in substance abuse, some are not working, some have gotten into depression. So we need to expand and think about how do we get them jobs, how do we get to the bottom of their problems and put into planning so that they can improve. But more importantly, we should start from the school setting. If we could integrate this as well in our curriculum, that if they come when they are very exposed, although we are trying it in the new curriculum, they come when they are exposed to many activities that they can do. They come when they are aware of problems that exist in the society that are waiting for them to be the innovative team that will provide solutions to those problems. I think that can also play. Thank you.
Thank you. A round of applause for her. Those are the issues we want to make sure they come out. And hand at the other end.
Good afternoon, everyone. What I want to say is quite close to what she said. People believe in their religious leaders a lot. A lot of times when they get issues, someone will want to say pastor, a bishop, a sheikh. I don't see them represented here, and it's one big gap that we actually have. We need to find a common ground where we can actually have them engaged, and these discussions should be held in houses of worship. Because most times we will give our patients the best care in a health facility, but we lose them to the houses of prayer. And I'm not disregarding that prayer doesn't work, it does work, but we need to give credit that the medical facilities have to be at the center of care of all the patients that are going through mental health breakdowns. The other is herbalists. I think we have more herbalists right now than medical doctors. Someone will believe in something given to them in a bottle without prescription, no calibration, no dosage given, but will drop medicines that are being given to them by specialists in a health facility. I wish we see how we can map out all the herbalists. I don't know how possible that can be, but it will be good for us to see how we can gain back that trust that the medicines being given at the health facilities actually work better than the herbs being dispensed on the streets and by random people, because it's causing more damages than we expect actually. Because a lot of times you discover that a patient has been under your care for a very long time, but a herbalist takes them into their care, and only for a month a lot of damage is done, and sometimes it's almost impossible to have them to recover and get back on their feet. Thank you.
Thank you. Thank you very much. I think she raises a very important point that we need to expand our stake of my life. We had a good family friend and in touch. Then I asked my father, have you heard from him? Then he said, oh, you didn't hear. He passed, he died. What happened? Oh, he died of stroke. And this was the herbalist who was giving people medication for what? Hypertension, stroke, diabetes, like killed by the very thing he has the medicine for. I was very, very touched. And I think you raised an important point that this is an important stakeholder we need to reach out to and bring them on board so that we can speak the same language. Thank you for raising that. There's a hand here.
Thank you.
Yes, they are first, then we come here.
Shame attached to mental health. We know that most of us have mental issues and we don't even know that we have mental issues. So some are genetic in nature and others are induced due to factors. So how are we going to segregate the two and then handle it? What you said last was also in my mind. How are we going to handle the people who handle people with mental health? Because in very many cases, being heard about people who die, mostly counselors, they die of depression themselves. So how are you going to handle this in M-Care, and specifically how are you going to handle those who are genetically, mentally disturbed, though they don't look mentally disturbed? Thank you.
My experts in the room keep a finger on that question and we respond to it. There's a hand here.
To add on this discussion of mental health, model. One, I want to agree with the rest of the people that the spiritual being needs to be tapped into. However, in our setting, more so the African setting, we cannot talk about mental health and leave out the home setting. I think I would love to see at what point are we talking about the home? Because in the home in there, like previously there is someone who said for nutrition, you just go to the facility to repair, but nutrition begins from home, good health begins from home. Just as that begins from home, even mental health can be treated or well handled if we, the people at home, are enabled or are given an enabling environment. We are given the capacity. We know, because if there is a mother, there is a father in a typical setting, then the rest of the things surrounding that, looking at the social welfare, the economic and that, all that will be sorted, and then we are able to fit into the integrated system. If I have a child who is mentally maybe disabled, I know I am economically, maybe I would say economically empowered, but I also have the knowledge that if I go to this facility, I will be able to get this attention and also help right from home. I submit. Thank you.
Thank you, thank you very much. You know, I think Dr. Yob made a nice presentation, and one of the root causes he highlighted was stress. And I get this feeling that it looks like our mental health is hidden in this thing called what? Stress. Different categories of mental health may be hidden in this depression, anxiety, substance use, and it's not coming out very clearly. And these issues have to come out, like you're saying, right from home. We diagnose you and really treat the real thing, not just saying you are stressed. Your stress could be meaning you are depressed. Let us classify you are depressed, you need help, and you'll be helped. Thank you for bringing that aspect of the home as far as this discussion is concerned. Another hand is behind there. You can introduce yourself and we get to know each other as we converse.
Yes, Dr. John Paul, and my name is from Oyam District, and you have Center for. I want first thank MCare for bringing aspect of mental health into other essential healthcare services. In my opinion, if you look into mental health is a component of the primary healthcare services that's supposed to be ideally provided. Unfortunately, mental health care services have been left at the tertiary levels. The primary healthcare facilities that are supposed to start and provide this mental health care service do not have trained personnel to offer mental health services. To me, this starts with the policy guideline and restructuring in the recruitment for facilities, especially in the primary healthcare facilities, the Mama Haradisi was talking about training and the new curriculum. All healthcare providers in their training, at least at one point, has had a hint on mental health. But a lot of things determine how we implement what we learn in school. And if you're being practiced in certain line of care, providing certain care, you tend to forget about the others. And eventually, you almost can't provide a service to a mental health patient. In my training, I first did clinical medicine. In some hospital, a mentally ill patient broke down and came to me. She wanted to say one of the nurses was his wife. Every staff ran away from the ward. I called the security people and we sedated the patient. The physician had left the ward. I had done the ward round with her
And so the man came to me and said, how do you leave me on the one of this hospital? And so everyone was not interested in touching this patient. And so this is the kind of perception even healthcare people has on mental ill patients. Then secondly, issues of now M-Care integration with mental health. I still think that it is possible only if M-Care could build capacity of the existing staffs. Because for now, this is a project with a timeline. Maybe policy may not change immediately to have healthcare providers who can offer these services. But building capacity of staffs at the facilities that will be selected can help to integrate mental health.
Thank you very much. That's a very insightful contribution to this conversation. Thank you. I see more hands. There's yes after Dr. Oki, then Dr. Rich, and next to him, then we can jump to the next table. Thank you.
Thank you. As far as medical mental health is concerned, all of us seated here, we are mentally sick. But the degree varies. If the degree exceeds the level, then it becomes a full-blown mental health. Yes, during the plenary discussion, there were some factors that lead to mental health, like alcohol abuse, drug abuse, in which people, fortunately, the panelists, none of them maybe take alcohol or abuse drugs. That's why they never discuss. Now, if you go to our street within the city here, most mental health is brought about by drug abuse. And these people stay in the community. And for us, of course, the facility has been identified to handle mental cases. But these mental cases are within, and the risk factors lie within the community. Now, the M-Care project is talking about the capacity building. We have community arms that support the facility. And of course, when we talk about capacity building and training, capacity building, I think, would be those who are already in the system, for the bigger capacity to handle mental health. While training, yes, you may bring somebody new and then train to handle mental health. But now, at the community level, if we empower this community arm, the queues, that is community health extension workers and the PTs, to identify for us, and also sensitizing community on those risk factors, so that yes, somebody may open up his or her mind and try to avoid those risk factors. Thank you.
Thank you very much. I think we are getting 3 serious answers from this conversation. Yes, Dr. Reg.
Thank you very much. I want to take from the presentation of Professor Umej, where he stated that this is looking at the primary health care facilities and then integration, making sure that the patient who comes, that 52-year-old who was presented there, comes to the health worker. And because the way I understand it now, this integration is not in the hands of the community person out there like the queues or the VHT. If they are brought to me at the facility, now that's where the benefit of coming to the hospital and then getting an integrated service should come in. I want to give assurance with the current system I know for Lira District. Let me start with Lira District to give us an example. I've worked at the 2 health center force where we have mental health workers employed by the district. And every year when we are doing our work plan, we don't leave out mental health. It appears in our work plan, meaning that the integration can be done Let me give a case of a match where I am the leader now. I interacted with Dr. Charashon and then the commission. We have integrated already, except that the integration at that level is still at the very primary stage, and it is still building up. Now, Ministry of Health has brought also the Here program, system to manage patients digitally. And it's just being hampered by a few computers lacking and something like that. But the team has taken it up very well. For me, I think I have assurance that the presence of the mental health workers who are also taking part in this launch makes it much easier to integrate. But my worry is at Health Center 3 and Health Center 2, where these staff are not hosted by design, by the program or by the system. So that means probably the project need to expand, as my brother said, to work with the mental health workers down there to move a little bit down, to empower the people in the lower facilities, and the cascade will be much well achieved. But because now, like for the others, we already have the personnel, so working with them, cascading down will be something that will be good enough to help achieve this, what we're looking for. Because the general health system even stigmatizes the mental health. So the empowerment, the sensitization of the general health system will be much needed by the MCare project, so that the health system can embrace all, because we say there is no health without mental health. Even if you're walking and you're so energetic, but your head has got disorganization, there's no health. So that's what I think. But then probably the MCare project might need to talk to the district authorities to consider employing more mental health workers and then posting them so that we can achieve this. Thank you.
Thank you. Thank you very much. And I think the conversation is taking shape. We are beginning to understand context. We are beginning to understand context of practice. MCare is focused on. Yes, after him, just let me finish this and then you can come in and then you take the microphone on the other side. MCare is focused on primary healthcare facilities. So we are talking about communities, Health Center 2s, Health Center 3s, and Health Center 4s. That's where we stop. And I think Dr. Rachel gave a very good perspective on the workforce that we find in these primary health facilities. And in the morning, when the Prof. Mate was making a presentation here, one of the responses he did provide.
Thank you so much, moderator. I am Benson Walter, the United District Chair of the local government. I want to quickly rejoin what Dr. Wright has just mentioned. It is good that a representative, the Minister of Health, is here. I don't know whether all we are aware the factors that drives towards what we're talking about mental health. Let us not narrow ourselves into those ones that we see them coming to health facilities. How about those ones that you don't know, the invisible ones? I want to give you a background that Northern Uganda, especially Yam District, Lira and elsewhere, we have been in war for some years. Quite a number of Ugandans, our young people, were abducted. A number of children are produced in captivities. They did not go for service or for prayers. They have never seen school. They have never gone to a facility. They grow up in that hostility. Some of them were rescued by UPDF.
They have been integrated into society and they are there. They are mentally tortured, trauma. They were meant to kill innocent people. They are there. When they come to a facility, you may think that is only mentally, maybe through drug or whatsoever. But the level of that mentality is beyond the thinking of the health workers. Therefore, when I want to appreciate the healthcare intervention, but it's a project of 5 years. How I wish that they should not only be integrated as we are talking of, the healthcare should be nationally rolled for us in the north to address the issues of trauma. There are mothers whose daughters were abducted and killed in their hands. They are psychologically traumatized. They have a lot of mental issues. That's why you hear some of them are killing their husbands. You hear some people are killing their own daughters and sisters. It's because of these mental issues that were imposed on them. Because they were young. They grew up there. My own daughter was abducted when she was 9 years. She never came back to date. I don't know whether she's alive or not. I don't know how many children she might have produced. But tomorrow, if one comes to say, this is your daughter, and these are her children, will you send them away? You integrate them. Some people have already integrated them. But the way they behave, and the way society perceives them, is very negative. So I want to appreciate the intervention, but the time is not here. Finally, we are talking of the level of how our society, our health workers handle these people. Some of them have gone through the same trauma. They fear when such people come to them. You don't know what next. How I wish ministry, the structure at health center did not include this specialist. The structure at the health center 4 have only one psychiatric nurse. How I wish this should be rolled up to the structure at health center, because there are very many community